I'm excited to be here. I want to welcome everybody. I see some old friends, which I say kind of carefully because when I was with in-home services at the health department, it's been about 20 years ago, so if you knew me then, you are an old friend, as am I. This is an exciting time for us. As you all know, we have gotten a lot of attention in Arkansas, national attention actually, about what we're doing with the healthcare system in Arkansas. Most of the attention recently has been about Most of the attention has been about our private option, how we now have about 200,000 lower income adults who have health insurance who didn't have it before, and that's a terrific accomplishment, and we're proud of that. But you may know that the attention for Arkansas really started with our payment improvement effort and really trying to transform the healthcare system in Arkansas. And that started 3 or 4 years ago, and I just as a reminder, I move forward here a little bit. As a reminder, we really started our health improvement initiative in Arkansas almost out of desperation, and really a sense that we couldn't take baby steps. This country does not have a very good healthcare system, but in Arkansas we have particular challenges. We have poor access to care. We have poor health status on just about any measure, whether it's life expectancy or how we deal with the chronic illnesses or the rate of low birth weight babies, infant mortality. You can kind of pick the indicator. We don't do very well in Arkansas. We also have a system that people find difficult to navigate. And that's particularly true for people with complicated situations, complicated issues. They find it's hard to figure out what's available for them, what's most appropriate for care. And then, of course, the healthcare spending has been out of control in this country, and it's been true in Arkansas also. That's really what caused us 3 or 4 years ago to say we've got to change the way we do business, is because the Medicaid budget was just out of control. We knew we couldn't sustain it. And we started talking with other healthcare providers, Blue Cross, QualChoice, others, healthcare payers, realized we had to do something different. Now, what you usually do when you've got a shortage of funding is you do the 4 items that are in gray there. You just reduce your payments to providers. That's one of your options, not something we wanted to do. You pass the cost on to consumers in the case of in higher premiums, higher deductibles, or in the case of Medicaid, you're basically passing that cost on to taxpayers. We didn't want to do that. You can kind of tighten the screws, which we've done in the past on Medicaid, doing more prior authorizations, making it harder to get the services that people need, and just in effect force utilization to go down. Or you can actually eliminate people from the program or eliminate services. That's how we normally control cost in the Medicaid program. But instead of doing that, we really wanted to look at how can we get more bang for our buck? How can we remove some of the inefficiencies and really start paying for what we want in healthcare rather than simply paying for volume? So we came up in our Arkansas Payment Improvement Initiative. We really came up with a comprehensive approach. And you can see our objectives were really, these are what are called the triple aim at the national level: to improve the health of the population, to enhance the client's experience, and to enable clients to take a more active role in their care. And with providers, rather than simply paying for volume, we really wanted to reward providers for providing good quality care at a reasonable cost. And of course, that would help us, we thought, reduce or control the cost of care, at least relative to what the trends were, which were really rising quite rapidly. And we're really taking a 2-pronged approach in the Medicaid program. And again, we're working with other payers because the feeling was all payers ought to kind of move in the same direction. First, we want to keep people as healthy as possible. And we want to do that by having every client have a patient-centered medical home where there's one provider, usually your primary care physician, who really takes some responsibility for making sure that you get the services you need, that your care is coordinated, that there's the follow-up, that referrals happen when they need to. And then for people with more complex needs, such as the frail elderly, people with developmental disabilities, people with serious mental illness, we want to have something like a health home where the provider who works more frequently with that client really helps them deal with some of the social issues and some of the support services they need beyond simply the medical care. So that's really kind of the population-based, trying to keep people as healthy as possible. And then we are creating episodes of care for when you do get sick, rather than simply paying the radiologist and the surgeon and the hospital and on, that group of providers who may be working involved in your knee surgery. Rather than paying them all separately and just paying for volume, we are really identifying one provider who has the lead for that condition or that episode of care and giving them incentives to really create the best care as possible, to use the most efficient approach, the most effective approach, to use good health information technology. We really want to get good outcomes, and we want to reward providers who can get good outcomes at a reasonable cost. And that's what our episodes of care are about. As you all may know, we've got about 12 episodes that we've implemented and more on the way. And that's part of what we're doing with the episodes of care and the patients in our medical homes. That's really part of a broader effort where you can say, I mean, that's really what is described there as results-based payment and reporting. But we're also working with the health department, with UMS and others on figuring out what our healthcare workforce needs to be and how to make sure we have the right mix of providers in the future. We really want to find ways to get consumers more engaged and have more personal responsibility, where they can look at information, they have more transparency about which providers are doing how well and what costs are, and they can kind of take more control over their care. And then finally, we're really trying to strengthen the health information system. My guess is there's not a provider here today who's not in some way using HIT or looking at implementing a health information technology system. If you can afford it, that's one of the challenges. But really trying to share good information between providers so we don't duplicate services. And we've had some good results so far. On episodes of care, just a few examples. With upper respiratory infections, we've seen almost a 20% decrease in the use of antibiotics. And as you all know, antibiotics are almost never needed for upper respiratory infections. So a reduction in antibiotics is a good thing, good both for our budget, but also good for the patient. We've seen the costs stabilize in hip and knee replacements and in congestive heart failure. And with pregnant women, we're seeing greater screenings for HIV, for hepatitis B, for diabetes. Providers are actually responding, providing better care at a better cost across a number of these episodes. And really the part that's been probably most gratifying for us is on the patient-centered medical home. As I said, we want every client, every patient to have a patient-centered medical home. We thought that would take quite a while to get in place because it's new for doctors, for primary care physicians to have their practice work as a patient-centered medical home. They often have to kind of transform the way they work. But we have found just in the first year, you can see we've got over 80% of our beneficiaries in Medicaid enrolled in a patient-centered medical home, either through Medicaid or through Medicare's comprehensive primary care initiative. So both the clients and the providers seem to understand that preventive aspect, really keeping people as healthy as possible, is very important. So a lot of success to date, but if you know the Medicaid program, you know that's what we do, what we really specialize in, is not just kind of keeping healthy people healthy, but we've really got to serve people with specialized needs. As I said, the frail elderly, people with physical disabilities, developmental disabilities, with serious mental illness. If we don't serve those populations well in Medicaid, and if we don't manage those costs well, we're not going to have done our job. And so we're very excited about the work we're doing. We've got work groups working on developmental disabilities. We've got a team working with the nursing homes, trying to make changes there. We're about to launch a new behavioral health initiative. And today what we're talking about is the changes we're wanting to do to improve the home and community-based care system in Arkansas. You all know we've worked for years to improve home and community-based services. I think we do a much better job than we did, but we've got a long ways to go. And I think through the work that's gone on over the last year or two, we now have a vision and a plan that's very exciting, and that's really what we're going to be talking about today. So I just, again, wanted to set the stage. What we're talking about today is part of a much broader effort to really improve care for people, to improve how we manage our resources, and for the state of Arkansas to continue to lead in this. So, Krista, let me turn it back to you, and you all can get into more details here.
Okay. So I would like to talk briefly about the vision and the goals of the HCBS payment improvement as John led us into this. You know, our division has had a mission for years and years, and that mission is to improve the health, safety, and independence of older Arkansans and adults with physical disabilities. And we've worked toward that just for decades, it seems. And so what we're doing with payment improvement here, I am very excited about, and I really do think that you all will be too as you start to hear some of the flexibility improvements that we're making in the programming, both for the consumer level, which always drives what we do, and as well as the providers for who are the ones who serve them. So just to give you a basic framework, we wanted to give you a little bit of information. So you'll see on your screen that there's about 14,000 folks in a given year that are receiving at some point HCBS services. In the nursing home, there's anywhere between 11 and 12,000 residents living there during the year. Our expenditures for LTSS, and again, that's an acronym that you'll start seeing if you don't know that already, and that is long-term services and supports. And so instead of LTC, which is long-term care, it's LTSS. And so it's roughly $890 million, of which about $157 million is represented on the HCBS side. And you'll see below that that's distinct buckets. And so it's the Elder Choices APD, Independent Choices Assisted Living and PACE. So there are some other HCBS services like through the state plan and that kind of thing, but those are the buckets that you're seeing here. Nursing home expenditures are around $733 million. When you look at, I don't know if you all know how many providers that we have in our network. So we have roughly 250 throughout the state for HCBS, and there's about 220 nursing homes. This slide says the HCBS journey over the last 2 years, and let me just say that this is in a nutshell because it actually is longer than that, and those of us who have made the whole journey. And you'll see on the left side of the screen, the same tenets that were in place for the payment improvement as a whole for Medicaid and for our state are the same tenets that we have to improve the health of the population, enhance the client experience of care, and enable the clients to take a more active role in care. And you will start hearing the phrase of person-centered planning. You need to learn that phrase now because that will be taken over in terms of care plan or service plan or whatever is participant-centered planning, because we have a culture change at hand, and that is to empower our clients that they are the ones that are leading the care and the decision points for what happens with them. Where this says the journey has been ongoing and it says 2013, we actually started back in 2009 or so with our decisions to move from the 703 assessment instrument to the RPATH, which we'll discuss later. So we actually had made the decisions to move into to take a process that would allow us to eventually move to some kind of a case mix or acuity decision engine for us before payment improvement really ever came along. And we were the first of the 3 divisions that are considered long-term care divisions, which John mentioned as behavioral health, developmental disabilities, and then Division of Aging and Adult Services. Of course, the nursing homes are also involved with that, and the office that kind of is their administrative body here for the department is the Office of Long-Term Care. So we've all been working on this for quite a number of years. Office of Long-Term Care has worked with us since the very beginning of time on this process, and we appreciate y'all hanging in there with us. But we have had different paths, we've had different involvement with this, and I think that we are to the point where we've had some critical decision points at this juncture with next steps pretty defined, and we're excited to share them. So we've had different workshops. Back in 2012, we started having work groups that combined both the nursing home network as well as our network. And I don't know if any of y'all were involved in any of those early days, but there were a lot of conversations that occurred. And we started having different meetings, and we found that more and more people were coming, so it was becoming quite difficult to compress so much conversations into such a diverse group. And so we kind of at that point regrouped, and we broke into a more targeted work groups within those 2 networks, within the nursing homes and within HCBS. And we're here today to talk about HCBS. I do want to recognize the members that have participated with us in the smaller work group functions since last year. And I will say it's been about a year. I believe last October is when we really really narrowed that down. And so what we try to do is get representatives from the provider world that represents the different types of providers. And so we had a government organization that has a large penetration in the state. That's the health department. We had the Home Care Association, which represents the health agencies. We had for-profit provider representation. That was primarily Superior Senior Care. They have a large presence throughout the state. And we have nonprofit provider representation. That primarily was with the area agencies. And let me just say, I want to say right now, these are not people that go out to lunch together normally. These are people that might have different agenda items or different priorities. But we charged them, with the task of get over yourselves get together in small groups, talk about this, bring us back priorities that are reflective of the entire industry, all provider groups, and let's work as a whole. And they were able to do that, and I really applaud you all. I appreciate it because I know it was hard. It was hard, and not everybody's priorities got, accepted or carried forward, but it was a consensus, and I really appreciate the work that was done. The tenets that were brought to us, that drove everything we did, was brought to us by that work group members, which were provider representatives. And they pretty much focused in these general areas here. Assessment and reassessment. You all know that we changed to the RPATH and that we had a very, very rough start with that. We are over that rough patch. We have got that working correctly. We'll touch on that a little bit. But the assessment first determines eligibility, and then we're looking toward that in the future to do some other things. But one of the things that our providers were very insistent on is that we have a way for providers to have input into our assessment and reassessment process, and that for denials on the assessments, we have a very meaningful process for reconsiderations. And Stephanie will talk about that in a little bit more detail in just a little bit. Billing. The main thing is nobody wants the 15 minutes. It's just, nitpicking to death. The billing, we have to fundamentally change how we bill. So that was just brought forth over and over and over again. Flexibility in services by the providers to have a little bit more control in the service delivery. That was an overarching comment made. Provider payment. We were given information on what rates are inadequate, what rates, how we should consider looking at the labor market rates and other ways to look at improving the rates so that we can not only keep providers, so that we can also build a robust industry out there for HCBS services in all counties, and we know that that is a major challenge for us at this time. Care coordination. I think you saw word health home and medical home on one of the slides. But one of the things we have to recognize is that what we do is a social model of care delivery, okay? It is a social model. We cannot cut that apart and have that in a siloed area over here, away and apart from the medical aspect of that client's care. And we have to figure out a way to build that bridge between the two areas so that, in fact, our consumers do have the best opportunity to have the best help that they can get. And care coordination is going to have it's just going to play a vital role going forward. We looked at our targeted case management program. We looked at health home opportunities, and we're still working on that. That's one area that we're still working on, but we'll share what we have with you today a little bit later. And then presumptive eligibility. One thing that our provider representatives kept telling us is that it's killing them. Our consumers are not being able to access services in a timely manner. The eligibility application process takes way too long, and as a result, people are either having to go to higher levels of care or whatever, but they're not able to get to these critical services as soon as possible, and so we have to do something about that. One of the phrase here is presumptive eligibility. I don't know how many of you might be familiar with that or who that might be a new phrase for. But what this says is there should be a screening process by which we kind of know pretty sure that this person will be found eligible once all the paperwork is checked off. And as such, we ought to fund those services to start sooner so that that lifeline and all is provided to those consumers. And so, again, we'll talk a little bit about this going forward. But that's what that is. We're currently working on a pilot to determine whether our screens are going to be accurate enough to do that.